We have 4 presenters today, Dr. Ray Dantes, Dr. Dan Pollock, Amy Webb, and myself, Mindy Durrance. Just a reminder, hold all the questions to the end, and we'll have questions and answering then. And then this session is being recorded. So, Amy, if you can proceed to Ray's slides. So, Dr. Ray Dantes is a medical advisor for NHSN, where he works on research and development of upcoming NHSN modules, including the proposed sepsis module. He is also an assistant professor of medicine at Emory University's hospital. So, Dr. Dantes, take it away.
Thank you very much. If we go to the next slide, please. So sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. So if you have an infection that progresses out of control, it will then progress to sepsis and then subsequently death. We know that early recognition and management, which includes measures like prompt administration of antibiotics and resuscitative measures, can save lives. There is wide interest in the CDC and among patient advocates, healthcare quality experts, and the clinical community for implementing sepsis surveillance via NHSN. Thus, development of a surveillance definition is underway. Colleagues from Harvard University, who have also helped us develop the VIE module, have led an ongoing study that extracted data elements from over 200 hospitals around the country using a variety of EMR systems to develop and test a surveillance definition for sepsis. If we can go to the next slide, please. I'll skip ahead one more slide here, actually, and we'll come back to that one. So here are the proposed data elements for the sepsis surveillance definition. It relies on fulfilling 2 general criteria. The first is the presence of suspected infection, and 2 is evidence of organ dysfunction. Suspected infection is defined as the presence of both a blood culture and new administration of 1 or more antibiotics for at least 4 calendar days. Organ dysfunction is defined as having at least one of the following criteria: either the initiation of a vasopressor medication, the initiation of mechanical ventilation, elevations in serum lactic acid level, acute renal failure, which is based on changes in serum creatinine levels, hyperbilirubinemia, which is based on changes in serum bilirubin, and thrombocytopenia based on changes in serum platelet levels. Now, if you go back to the previous slide, thank you. This is a draft of a sepsis surveillance form that can be useful for trying to visualize what this would look like. If we can go forward 2 slides, please. All right, thank you. So I do want to emphasize that this is all a work in progress, and the reason I'm presenting this today is because we would like your feedback early on in this process. We have been promising our users that we are very committed to reducing the burden of data collection for NHSN, and we're also committed towards moving towards quality measures that can be extracted directly from an EMR. So for this to all work, we do want your feedback and your partnership to understand whether a quality measure for sepsis based on these data elements could be obtained, packaged, and reported to NHSN in the future. While, of course, our ongoing research project has demonstrated that it's feasible to extract these data elements from over 200 hospitals that use a variety of EMR systems, there may be challenges that you can identify that we have not yet anticipated. So myself, members of our CDC sepsis team, as well as our research partners will be reaching out to you in the future individually to request your feedback, and I just want to thank you in advance for your thoughtfulness. And you guys can take it away from here.
Yes, so up next, we're going to be moving into the antimicrobial use and resistance section of today's webinar. And first, we're going to start off with Dr. Dan Pollock talking about the Synthetic Data Project. Dan?
Yep, thank you, Amy. So the slide, NHSN Antimicrobial Use Data Validation Synthetic Dataset Project should be up and describes the project goals, process, next step, and wider use. So the deliverable and goals, we're going to work with the VA to develop an automated and scalable solution for validating vendor implementers' configurations for aggregating AU numerator and denominator data. These are data that need to be aggregated to produce AU output files, and those files will serve as the target by which we will provide feedback to vendors on the completeness and accuracy of their aggregation using the test data, using the synthetic data. So our near-term goal is to develop this approach as a way to assist vendor implementers with their AU reporting implementation. So when the implementations are being configured as a work in progress, we want to be able to provide a resource, in all likelihood through our vendor portal, that will enable the synthetic data use, the synthetic data sets to be absorbed and processed. Longer term, we think that the approach, if successful, can actually serve to enable a systematic test of implementations in which CDC would then be in a position to publicly acknowledge successes. Our process is, and we're working with the VA on this right now, is to provide to requesting vendor implementers synthetic AU data sets, and the VA has developed an initial set of these comprised of patient-level numerator and denominator data, so antimicrobial administration data and ADT data. The vendor implementer would use the synthetic data sets and their own system for aggregating the numerator and denominator to produce AU output files. Now, these would not be CDA instances. These would be a file that would not require creation of a CDA. And the output files would, however, need to meet our specifications, and we have yet to nail them down, but we think that they will be a very low bar in terms of the output files themselves. We'll have an answer key when the output files are delivered to CDC, so we'll automatically check the AU output files and provide feedback to the vendor implementer on any errors or omissions that have been identified. Our next step is that CDC, working with a group at the VA based in Salt Lake City, Utah, will work with a group of vendor implementers who've volunteered to participate in a field test of the synthetic data sets for data validation. So we introduced this topic at the APIC meeting, the annual meeting last June. We said we'd follow up with individual vendors, and we have a group of 5 vendors that have volunteered to participate in the pilot project. If other vendors are interested in joining, please let us know. Just send an email to the CDA help desk email, and we can follow up with you and talk through with you what we have in mind for this pilot project. Wider use, beginning in 2018, we'll set our sights on enabling vendors who haven't participated in the pilot, as well as those who have, to use the synthetic data set approach in their implementations. So that's a quick overview of where we are and where we want to head over the next couple of years with this project. Amy, I'll turn it back to you.
Thanks, Dan. So next up, I'm going to talk about the 8.6 updates for the AUR module. Many of these we've already highlighted with you in the spring vendor webinar, but with 8.6 quickly approaching, we wanted to go over them again, just in case you had any impending questions. So on this slide, you can see CR 1466. With this CR, we've added the ability to report specimens from the AR option in the select outpatient locations. So those 3 outpatient locations are the emergency department, the pediatric emergency department, and the 24-hour observation unit. You can see that in the screenshot here on the slide. You would find that in the IDM on the location codes tab. The next slide highlights CR 1560. And with that CR, we've updated, again, the AR option specifically the specimen SNOMED codes to include child SNOMED codes for additional blood and urine specimens. So previously, we had one single specimen code for all blood and all urine specimens. With 8.6, we've expanded that list quite substantially. So now there are a number of different specific SNOMED codes for specific specimen types, as you can see in the R8.6 screenshot on the bottom right-hand side of the slide. And again, you can find those specific details in the IDM. Additionally, CR 1561, we have updated the pathogen code list that's specific to the AR option. So we've added a number of species-level codes specifically for Acinetobacter and Enterobacter, so you can find those in the IDM also. It's important to note that when you do submit, for example, these specific species-level Acinetobacter codes, NHSN will roll them up and report them into the Acinetobacter category on our end. So we would like vendors to report the specific code as granular as you can get. And to kind of tie those two CRs together, there is some important things to keep in mind when you're thinking about the AR option duplicate rules. So as a reminder, the AR option will check the following variables for duplicates. So it'll check the patient ID, the specimen collection date, the specimen source group, so that's invasive, that means all blood and CSF, or non-invasive, all urine and lower respiratory, as well as the specific organism SNOMED code. So in order to highlight some of the nuances, I've provided a few examples on this slide. So just taking the first two rows for patient ID 123, so that patient had 2 specimens collected on the same day. One was technically an arterial blood specimen, and the other was classified as a whole blood specimen. So those are 2 separate SNOMED codes. However, in NHSN, those both roll up to the blood specimen source group. Within both of those specimens, Acinetobacter juni was collected. So are those duplicates? The answer would be yes, because NHSN considers them duplicates because both are blood specimens and the same organism was identified in both. So the next example, patient ID 456, the middle 2 rows in yellow. Again, the patient had 2 separate specimens collected on the same day. One specimen, again, was an arterial blood specimen, and the other was classified as a whole blood specimen, so 2 separate SNOMED codes. Both, however, again, get rolled up to the blood specimen source group. However, this time, the patient had 2 separate organisms, 2 different types of Enterococcus that were identified in those specimens. Therefore, they are not duplicates. They are 2 separate organisms. So both could be reported into NHSN. And then lastly, patient ID 789, the bottom 2 rows on the table. Again, the patient had 2 specimens collected on the same day. Both were urine specimens and used the same specimen source code. There were technically 2 different organism SNOMED codes identified in each of the individual specimens. The first was just Klebsiella pneumoniae, and then the second, the lab categorized using the SNOMED code specific for carbapenem-resistant Klebsiella pneumoniae. So it's important to note that for these new organisms that were added to NHSN that have the susceptibility description in the organism name, so this one says carbapenem-resistant Klebsiella pneumoniae, those will be rolled up by NHSN to the organism without the susceptibility description. So when you upload that into NHSN, it will automatically roll that up to a Klebsiella pneumoniae, and therefore that will be considered a duplicate. If you have any questions about the duplicate rules, please feel free to reach out to us. We know that it can be quite nuanced, and this is a newer reporting option for vendors and facilities alike. So moving on, we do have an additional update about the antimicrobial resistance option schema. So please note that you need to use the updated R1 norm schema, which allows the new blood and urine specimen type codes to be included. The schema has been updated and was included in a email that was distributed in October. You can either reference that email the CDA help desk for the new version, or you can use the link listed on this slide to get the direct link. And then lastly, just to highlight, the 2017 AUR module protocol has been posted on our public website. You can get to it directly from the link on this slide. We did make a lot of simplifications and clarifications to the 2017 AUR module protocol. However, nothing that we've changed in the protocol will affect the development of your CDA files outside of the CRs that I just previously covered. I will point out that all of the 2017 protocols have now been posted on the website. You probably saw that last email go out. I believe it was sent either late last week or early this week. So you can find, for example, the updated BSI, UTI, all of those protocols have now been updated with the 2017 information. And with that, I'm going to turn it back over to Mindy for the MU3 certification setup and reports section of today's call.
Thank you, Amy. Next slide. So we're going to discuss the Meaningful Use 3 that was qualified as a new Meaningful Use 3 objective, or to sign up for NHSN to send AU antimicrobial use and AR antimicrobial resistance data into NHSN. So I think we've talked about this in some of our previous webinars. So we'll start with this one, just to remind the vendors and homegrown systems, you need to send AU and AR CDAs to the ONC Health IT certification program. So this is for both vendors and facilities that are able to create CDAs in-house. You'll want to get your certification for the Meaningful Use 3 for the AU and AR. This is on our website. If you need it, you can go there, and it has all the links to it. Next slide. There we go. So we're going to talk about how to sign up and register within NHSN. I know that the vendors, you will not actually do this. However, we feel it's important for you to know so you can assist your customers and understand and doing it. So first of all, I want to point out that's a snippet of the user interface. There's a new look to it, and you'll see that once we get the pre-production site up. But you'll see a little new look to it, more updated, so it might look a little bit different than you're used to. So only the facility administrator will be able to view the AUR MUC3 registration link. So if you're not logged in as a facility administrator, that link will not be there. So facility administrator logs on, they click facility, AUR MU3 registration, and then it'll take us to the registration page. Next slide. So this is a view of the registration page, and we're going to quickly walk through it. Basically, it says AU and AR has been identified as an option for public health registry reporting under Meaningful Use Stage 3 by checking this box, and you'll see the underline. Once the facility administrator clicks that box, it will auto-fill their name and the facility information. We have basically the rules that apply to this once you sign up. Active engagement. means they must report AU, summary, AR, event, and AR, summary, data for a full calendar year. And then per meaningful use rules, the reporting to production must begin within 60 days of registration. You'll see the facility administrator down below. The email is auto-filled, and there's actually 2 other spaces for optional emails. And what this is for is reports will be generated and returned to the facility administrator and the users for their optional emails. And then you'll see highlighted in pink, it has date registration of intent completed. And of course, this is a mock-up form, but we'll say they signed up next year, at the beginning of next year. Then it has reports button, and we'll talk more about that later. And then actually it does have a save button on the real application. So I just wanted to point this out. So vendors will need to discuss ME3 registration with customers, because you do not want them signing up if they're not ready to send data, because they're supposed to send their data within 60 days. So I want to make sure that you are aware of that, and you can give guidance to your customers. Next slide. So once they say yes, they want to sign up, a pop-up alert says, "Are you sure?" And it reminds them once again that they need to, are they ready to send production data within 60 days? If they click no, it takes them out of that registration page and everything, and they can wait to do it later. If they click yes, then as you see on the left, it gives you a little pop-up that says registration successfully saved. And once they sign up, it cannot be removed. The optional emails can be changed. And then if there's a change in the facility administrator, then the facility administrator email, once they sign up, reassign it, then it'll be auto updated. Next slide. So once they sign up, this is a letter that is auto sent to those 3 emails, and the user would need to save this. It shows that they signed up for their intent to send data, and then it says, it reminds them once again that they must report their data for a full year, and then the next steps are to report production data within 60 days. Next slide. So the reports are sent via email, and they're attached to the facility administrator in the optional 2 emails. And the methods are, there's an automatic email sent, and then there's also an ad hoc request within NHSN, and I'll show you that in a minute. And then the AUR data is displayed by month for a requested year. Next slide. This is an example of just some screenshots of the attachment, the email in the attachment, how it may look. So example for your first one for a monthly report. If a user signs up in January, a monthly auto-generated email with the report attached would be sent during the months of March 2017 through February 2018, displaying the status of the AUR 2017 data. And then for the annual report, it will be sent on the following year on February the 1st, and this will serve as a final query for the previous calendar year. Next slide. So NHSN in the protocol, I know Amy talks about this too, it's recommended that you upload your data within 30 days following the completion of the month. And this is just the schedule of the automated reports that will be run, and then the report type that'll be sent out. Next slide. So now March is here, and they've been submitting their data, and this is an example of the report that will be sent to the emails, and it'll state the status report, and it'll tell the date as of March the 1st. Once again, we remind them active engagement is reporting for a full calendar year. And then at the bottom, the display of the data for January, at the bottom, that's a long form. I just couldn't fit it on one page. It'll have a table, and it'll show the month and whether or not data has been received for the AU and AR. If it has not, it would have a no in there in the table. Next slide. So once a facility has reported their data for a full calendar year, this is the annual report that's emailed, and you can tell it's February the 1st, 2018, so it's the next following year, and then the table that's displayed and shows they have submitted data for all 12 months for all 3 types. And the facility user would need to save this for proof. Next slide. So as we mentioned before, there's ability to do ad hoc reports. Say you lost your email. So on the registration page, only the facility administrator can see this page, right? So they would click on reports. Next slide. And then once they do, they have the click for a drop down, and they can select the year, and then they can select the view report, and then you can see it's the same report that we already viewed that was sent out. Next slide. And they can also have the choice to email the report to themselves, and it'll say confirmation. Click yes, and then as you see at the bottom, it says that the report was successfully emailed. So that's pretty much how facilities will sign up and use the NHSN application for Meaningful Use 3. Next slide. So next, we're going to talk about NHSN Release 8.6. As Amy said, some of this is, hopefully you already know it, because I think we've been getting lots of good questions in our mailbox as you're preparing your code for the NHSN 8.6 release. We do have a few things that have been added to it, and maybe some updates for others. So we'll go through these. So you got the Blastees email. So the schedule, the deployment schedule has been changed from December the 10th to January the 7th. And the business rules that will be effective January the 1st. So even though it's coming after, and I think this is pretty much the way we've normally been deploying. High-level list of changes is there's a new CDA for hemovigilance denominator, and the ALICE's numerator and denominator have moved up to another version. The pathogen code list and business rules were updated. There was an additional C. difficile test method code. Some other various business rule updates. We've had an update of ICD-10 and CPT codes, and option for multiple direct addresses per facility. And some of the, we'll talk briefly about some of the defects that have been fixed that were related to CDA. Next slide. So these are the, thanks to you for reporting them. Defects have been addressed, and the fixes will be included in this deployment. So there was an issue for Lab ID, when there was the same patient, same day, but a different MDR pathogen, it errored on the import and said it was a duplicate because it was going by the patient and the date, much like, say, a BSI. But that's not true for Lab ID. So now that's been fixed, and the same patient, same day can report multiple different MDR pathogens can be reported. The same thing was happening on procedures that allowed multiples, like hips or knees if it was seeing it as a duplicate when really it wasn't and it was allowed. So that has been fixed. We found a antimicrobial resistant option issues, similar as the lab ID issue, same patient, same day, but different pathogen. It saw it as a duplicate when it really wasn't. That's been fixed. And succession management rules have been, the format and the rules have been sort of shored up for AR. And I think there was also an issue in an MDRO, the other C. difficile test method. There was a free text value was not displayed in the user interface, and now and that's been fixed. So thank you as always for reporting any issues you find, and we'll continue to correct them. Next, we'll talk about briefly about the hemovigilance component. So if there would be a new CDA coming out, it goes by the implementation guide, the R3D1. For data for 2017 and forward, summaries, you will be able to send in the CDA. It includes ISBT data that's at a which is more granular than the user interface shows. And it will be displayed using analysis and reporting function. And as you can see in the snippet, if you're used to looking at that form, for example, there were 20 total discards for whole blood, and it'll break it down and say for 8 and 12, for each individual ISBT code, how many total discards there were. We will have a separate webinar to review in detail. We'll go into the CDA and so on. Maybe hopefully in December we'll have that. All right, next slide. Dialysis component we'll talk about next. So as you know, the numerator and the denominator are moving up to be based on the R3D1 version. I know y'all are used to the numerator moving up, but the denominator has been at the R7 from the beginning. So this is the first time it has moved up to the new version. And highlighted in yellow are the additional questions that were added to it. Patient's dialyzer is reused, and the answer equals yes or no. And then conditionally required, if the IV antimicrobial start equaled yes, then it added the new question, was this a new outpatient start or a continuation? So those new fields were added, and that's why we had to move up to a new IG version. And those will apply for 2017 data. So for the dialysis denominator, the number of patients for whom dialyzers are reused was added, and that's why that CDA got moved up to a newer version. So once you start beginning the event date or the summary date for 2017, those CDAs will need to be in the newer version. Next slide. The pathogen, so CR 1422, the pathogen codes were updated, and even though it sits in the patient safety area, it does, the same pathogen list is used for dialysis. And then also CR 1507, the unusual susceptibility alerts, was added to the dialysis component. And I know as a vendor, there's nothing you need to know. It's more on the user interface side, but you need to understand how it all works. And there'll be alerts, and the user will go in, and as you can see, there's an arrow. They'll go into their unusual susceptibility profiles, and then it'll ask them, is this correct? You have to confirm it, or you need to go back and correct it. Next slide. There's also the 21-day rule has been implemented for dialysis events. So it will be validation on patient, location, and event type. And it's based on the IV antimicrobial start, positive blood culture, or the pus redness or increased swelling. So you will get an error message will be displayed if combination is less than 21 days from the same patient location and event combination. So whether you do that manually enter it or CDA import, you should get the same error message. And refer to the IDM and protocol for details. Next slide. Just a reminder for backward compatibility, as we said, the numerators move into the R3D1 version, and the denominator also move into the R3D1 version of the IG. Next slide. So now we'll talk about the patient safety component. I know we've had a lot of questions. The addition of approximately 1,000 pathogens. All your columns, the business rules and pathogen names changed. The new list, let's talk about this. We're getting this question quite often. The new list is valid for past and present data. So once that code is put in, deployed on January the 7th, I believe, this new list of pathogens will be applied. So if you import 2016 data in January after deployment, you're still going to need to use the new list of codes. If an old event is edited, then the user will need to will see the new list. Backward compatibility is used for codes that change for the actual SNOMED codes. This also affects the MDRO definitions and unusual susceptibility alerts tabs, so make sure you look at those in the IDM. And events affected are antimicrobial resistance, BSI, UTI, SSI, lab ID, and dialysis. So non-CDA events are those listed that it actually affects also. CR 1470, Salmonella species no longer reported for BSI and LCBI or BSI MBI. So we added a new column named LCBI to the IDM, and so that's what you need to go by. X means to include. And then also the column for the MBI pathogens has been updated. Next slide. There was also a bit of CR 1508 requesting that fungi no longer be reported for events in the patient safety and long-term care facility. So what we did was add a new column as patient safety and long-term care facility component organisms. So X equals the allowed organisms. And the reason we did this is to have flexibility going in the future to be able to edit that column. So if the SMEs decide they don't want something else reported, then we may start reducing that list some. But we'll keep you posted. All right, and just a reminder, there's no CDA import for long-term care component right now. Next slide. So this is a screenshot of briefly of the IDM, just to give you a visual for additional columns added were the patient safety and LTCF component organisms. So they're in green, LCBI pathogen, and you'll notice on your new codes are on column Z. So make sure you look at that. And you can see on column AC on the last, on the far right, that's where notes were made to update to inactive, add. So make sure you use those. We've actually made quite a few inactive. And we have found this out, that hemovigilance column is actually a list of pathogens per the protocol. However, all those pathogens are allowed to be reported for hemovigilance. So what we're going to do next year is we will totally remove that column, that hemovigilance column I, from the IDM, since there's no rules. It'll be similar to like dialysis. They use the entire list. Next slide. So CR 1531 is the R2D21 Lab ID CDA. The below questions will become optional if manually entered for events beginning January 2017, and that's the key thing to remember, manually. You must continue including them in your CDA because of the schema. Those rules are built in, so we can't just take them out, but you can always use the null flavor or unknown, whatever it is per the IG specification. But make sure you remember that it needs to stay in the CDA. It expects that format. Next slide. So CR 1551 SSI business rules change. Once again, thank you for your questions. Made us go back to the SMEs and ask their opinion. And actually, we noticed there was actually a discrepancy between what we understood and their updated protocol. So there has been a change. I will send out a new IDM by the end of today or tomorrow. So make sure you look at the specific event criteria BR tab. There has been a slight change in the rules for the SSI or GI for GIT and IAB. So I wanted to really point that out. And then also for the ICD-10 and CPT code update, we've actually, I just uploaded a new tab for procedure codes. The good news is there's a new tab, and we think it's good to go. However, we do not have all the details on which codes were changed. So I apologize that for Upright because that's what was given to us. So I'll have that in my notes that go out with the IDM, and it'll there are a few details, but there's a few procedure codes that you're going to have to look at the whole replacement for the new codes. Next slide. Addition of a C. difficile test method. So make sure you include that in your coding. The NAAT plus EAE has been added, and just add it to your C. diff test method, your value set. Next slide. Just a reminder to use the locations tab that is in our vendor IDM, and look for any changes that have been made. These are nothing since the last one we sent out, but just make sure you're aware of this. Next slide. And also a reminder that the business rules for the patient Medicare number validation, it's only a warning when it's manually entered. Warnings do not appear for CDA or CSV imports, but just be aware of the new format. Next slide. Now for a few general NHSN updates. So direct CDI automation, right now we have 12 vendors and approximately 3,700 facilities. I think it's actually 37 plus, sending via direct CDA automation. Batch submission process, there's no immediate reply. The turnaround time is based on the volume of the messages in the queue. We are continuously working to improve the process. If you are a new vendor, that want to do direct, then we have a direct toolkit on the NHSN website. And also, before you get too far along, we recommend you schedule a call with the CDA team to discuss process and lessons learned, and I'll get the direct database administrator on the call with us. I think it'll save you a lot of time. If you are a facility user on this call and you are interested in direct, if you have need to ask your CDA vendor. All right, next slide. So this is a new CR that'll be available in January. Our crystal ball wasn't working very well when we started doing on multiple direct addresses, and we never thought that a facility would have more than one CDA vendor, but that's what's going on. A lot of it's due to the pilots and awards and so on, but there is a need, and this is what when the user logs on, they will see they'll have different spaces to add additional direct addresses. So they'll fill out one. What we're thinking the real scenario is the facility already has one direct address that they're using, and then there's a need to add another. At that time, they'll click the where the red arrow is. They'll click Add Additional Direct Addresses, and they'll fill in the information and click Submit. Those back and submit buttons will loop down with you. So that will be a new process starting in after the deployment. Next slide. So I want to discuss our CDA version support. As you know, as we've grown, we have many versions of IGs that we use. So because of the large amount now, we want to concentrate our attention and to support the CDA versions for the current and upcoming year. So there, as you can see, I have highlighted in red. So basically, we'll support versions that are valid for 2016 and the upcoming 2017. As you can imagine, our QA team, as we rolled forward, was trying to keep up with all the different versions, and it was just a huge burden. So we want to make sure what we're doing now and what we're going to do next year are correct. We're not removing the ability to import older versions, but if there's an issue, it will probably be way low on our priority list to fix. So we'll just focus our resources on current data. Manual entry is a backup, and we don't foresee this being a huge problem based on, y'all pretty much keep up with us and stay with the current year and then the next year. But this is how we're going to handle it going forward. Just want to remind you, this guide to CDA versions is on our website, and there's the link below at the bottom of the slide. Next slide. The pre-production test site, I'll start with, sorry it's not up yet. They are working on it. We're having to roll back and redeploy some code. And anyway, it sits in another area of the CDC, so we're working with that group as we speak, but we've been having some issues. So the CDC pre-production vendor site is for the new users. It's a copy of our development environment. There's no SAMS credentials required. And to enroll, if you want to get access, just send an email to our CDA mailbox, and we'll get you going and signed up. So when it comes up, hopefully next week, you'll be able to test the new versions of dialysis, new CDA versions for dialysis, and the HV denominator. And just a reminder, there's no analysis and reporting available. So you can import your AU and AR data, but you can't view it. At At the login, read important message, and I'll try to put in the things that are valid to be tested and maybe things that are not ready. And just a reminder, a mock date of May the 1st, 2016 is for 2017 data. So when you're doing your testing, just remember that. If you do it from April back, it will use the 8.5 code. And we are actually we're moving to a more stable and robust environment. We're going through some checks and scans and so on in that environment. It's another different, robust environment. So we're moving forward on that. So hopefully that'll be ready next year and it'll be more stable. That will have analysis and reporting in it. So you will be able to view your data for AU and AR. Next slide. The LDF IDM status, they are still working on it. I think we're getting really close. We've uploaded actually all the 8.6 IDMs are in there. I think we'll roll it out next year, and we'll have a training webinar and give you guidance on how to use it and so on. It will be the phase 1. It'll be to view and download. We'll have it per version and per component. And then as you can see highlighted in yellow, you can see version, component, and tab. It is going to be a little bit different. I've been combining several different IDMs to what I call the vendor IDM, and we'll need to include in our training where to go for different information in which IDMs. Next slide. Just a quick slide on the innovation tools. They're currently working on prototyping a location mapping table using fire services that would allow a vendor or third party to access a facility's location mapping table. We know y'all been asking for this for quite a few years now. They're also working on prototyping synthetic data type for neonatal late onset sepsis. That is also going to be a future CDA import, and they're working on the protocol and so on as we speak. And then also they're building a fire interface to the IDM server to allow value sets to be retrieved as a fire resource via a RESTful service. So a lot of R&D is going on, and we'll keep you posted on any updates we have. Next slide. Future CDAs. So for the next year, January 2018, there'll be an update to the dialysis numerator. So that'll have to be moved to a new IG. And then there'll also be an update for the hemovigilance denominator. I believe that IG is going through HL7 publishing now, and it is called R3D1.1. That's what we'll be using. And then also, we're working on ventilator-associated vent to become a CDA, and we're scheduled to deploy that in January 2019. We're also going to have healthcare personnel influenza vaccination summary, which, as you know, they call it the flu summary. That will become a CDA. And then we're going to have a BSI, the bloodstream infection numerators, getting 3 new fields added. So all those will be in the flu summary, will be new CDAs, and the BSI will be updated. And in the future, the late onset neonatal sepsis, also outpatient procedures, and possibly, as Ray said, adult sepsis will be added for all CDA, new CDAs for our future. So it's a lot coming. Next slide. As always, we welcome feedback. We'll send out the new IDM updated. Please see the notes for as much detail as we can tell you about the changes. And actually, it's the delta from last time to this time. And please let us know if you ever need a webinar sometimes it's easier to have an hour webinar than to exchange, 50 emails. So we're glad to work with you to help you about with your CDAs. Next slide. And that's all we have for today. We'll open the lines up for questions.